Okay, so why don't we go to the next step in making our final impression of our implants. Here we have 4.3 diameter Hahn implants surgically placed in the number 19 and 28 sites. We had either cover screws and burying the implants, or we had taller healing abutments, 3 millimeters or 5 millimeters, or even custom healing abutments, which will allow a more accurate contour of the soft tissue. But at this situation, we have the implants uncovered. You see the internal design of the implant itself. And what we'll do is we'll go to your prosthetic kit, and if I can read upside down, in the first box here we have a Hahn closed tray impression coping for the 4.3 diameter implant, and I'm kind of pointing at it. Then we'll also demonstrate the open tray technique on tooth number 29 with an open tray impression coping. We have two laboratory analogs which duplicate the internal design of the existing implant in the mouth. And then let's demonstrate the Hahn anterior scanning abutment. For the anterior, they're a little taller, and in the posterior. We'll make our impression using the Capture Crown and Bridge impression material. We have a heavy body available and a medium body available that we will inject around the implants. Obviously, when we're doing our digital scan, we don't use our impression, and I use the 3M True scanner with great results. Finally, in the box is an acrylic try-in jig, and we'll demonstrate how to use that in a few moments after we seat the crowns. That's used to stabilize the prosthetic components so that we don't over torque the screw nor rotate the implant out of position. So let's go ahead and use the Hahn hex tool, and we will engage the closed tray impression coping and simply thread it into position. Now, we've said this several times in our lecture, it's imperative that we take a radiograph when we have a metal-to-metal component. You want to make sure that you have complete seating. Sometimes it's difficult to see subgingivally, so always take a radiograph. And in the number 28 site, we'll use the open tray, and then we can demonstrate the difference of the two. And again, using the hex tool, and I'm simply tightening it. And again, we would take a radiograph to ensure a complete seat. And you can see the difference. The open tray has a screw that's much taller that will penetrate through our impression tray that we have, and after the impression is set, we will unscrew it and the transfer assembly will come out in the impression. In the closed tray, the impression coping stays in the mouth, the impression is made, and then we would remove it, and then the laboratory would put it into the impression. So we had these custom trays made. Many times we're going to go ahead and fill the tray with our heavy body material. Good practice, builds up the muscles. And then we will take our medium body and we'll inject around the implants completely, as you do in the mouth. I'm trying to avoid bubbles and things like that. And we will simply make our impression so that we can then see the longer screw of the open tray concept. So after the material has set, the set time is probably around 4 minutes or so. With the open tray, we're going to place our hex tool, unthread the screw. Now it's important here that you make sure that the screw is disengaged, or you're going to end up doing the impression again. You can see it moved up and down, so it's released. So then we will simply remove the impression, and you will see that in the number 28 spot, the open tray concept has removed the transfer assembly, but on the other side we have a nice clean impression of the closed tray impression coping. Real nice crisp impressions. With the closed tray, we will then remove the closed tray impression. And then we will go to our laboratory analog, which is a duplication of the implant, and you will see how the parts fit together. Tighten them. Now you can see in the impression copings there are some notches or grooves here which will be duplicated in the impression. You have two options. You can either place these impression copings in yourself, but I would prefer that you send it to the lab so that they will put them in properly with loops and things like that. So I would send this to the lab. You can send the other lab analog, and we can show you how to do that. You place that lab analog in position, and again going to your hex tool, tighten it down. And you can see the lab analog is now securely positioned. The lab will then pour this up and make a master cast and then scan it for final fabrication of the abutments, custom abutments, and final crowns. The other approach that we have is using a digital scanner, in which situation they're all custom made for the Hahn system. And again, you simply place and thread it into position. And then do your digital scan on that. Same with the posterior one. We can go to the posterior area and simply thread it into position, and then do your digital scan, whichever scanner you have available. So our dental laboratory will then fabricate either a screw-retained prosthesis, a screw-retained crown or hybrid, or a cement-on, meaning they'll fabricate a abutment. As I mentioned, I like custom abutments. I like my margins to be at or just slightly subgingival. And I love the Bruxer and Bruxer anterior aesthetic materials. Here we'll demonstrate the use of the screw retained. You can see the access hole and the abutment and crown are all one piece. So we'll then go to the number 28 area. And this is wonderful, and what I really like and I appreciate about what Glidewell Lab does for me is they give me precision, so I don't do a lot of adjusting. So once we agree that the prosthesis is fitting correctly and the margins are correct, the occlusion's correct, we would then torque it to 35 Newton centimeters, and then we have that access hole that needs to be covered. And what we'll normally use is polytetrafluoroethylene sealing tape, or you can use a cotton pellet, but we'll simply cut a little piece of this material. We'll cut a little piece of this material. And then what I will do is I will just ball it up. And then go to my access hole and plug it in there firmly. And what this allows us to do, this is kind of a safety device. Obviously the patients aren't going to like a access hole showing, but I'm protecting the top of that screw. So if I ever need to remove this crown, I can. As we talked about, retrievability is important to me in my years of practice, because sometimes patients don't know if they're going to accept treatment or not. They may be biting their lip or biting their cheek, or food's trapping a certain way. Sometimes teeth will move, causing a food trap, and it's always nice to be able to retrieve the implant. The reason why we do a screw retained prosthesis, we've discussed cement going subgingival, causing a periodontal defect or periodontal problem is one reason, and again, retrievability. Then what you can do is just take your nanohybrid composite material of the proper shade and fill the top of the access hole, polish it, and the patient has an acceptable tooth. Now, if we decide to do a cement-on crown, we will take a custom abutment, titanium or zirconia, and again, we will place it to the site, and normally they mark the facial aspect. We'll hand tighten it. Take a radiograph to make sure you get a proper seating, and you can see the margins are just at or slightly subgingival, which I like, which allows for easy removal of cement. Now, you want to torque this abutment in properly, so you'll use a jig, a seating jig, and then you'll take your torque wrench, set it to 35 Newton centimeters, and simply torque that abutment into position. Again, you'll take your cotton pellet or your polytetrafluoroethylene tape and place it into the screw hole. Okay, and then I'll either put a little cavet on top of that just to seal it. Again, you want to be able to get access to that screw if this abutment ever comes loose, or if a tooth migrates and you have to change the crown. I always want to be able to get back to my implant. Now, personally, I cement all my implant crowns, and have for over 30 years, with soft cement. I didn't say temporary cement, I said soft cement. There are different brands. You can use Temp Bond or EBA, or even there are some implant cements out there that are removable, and allows me to remove the crown, get back to the abutment and unthread it, as opposed to not being able to remove the crown. And I tell my patients it's a soft cement. As far as they're concerned, it's permanent. If I use a hard cement and something changes where the crown has to be redone, we would have to start all over. And my patients have been very, very responsive to that for many years. So when you're cementing a crown, an implant crown, you are just putting a ring around the edge. You're not filling it completely because of the hydraulic pressure. And you will place the crown, and you can see we have a magnificent final restoration using the DrKosinski material, which I highly, highly recommend. Floss, clean, make sure there's no cement. Take a post-operative radiograph to make sure there's no excessive cement subgingivally. So let's practice on this, and I think that we'll get both the surgery and the prosthetics very, very, very nicely.